Welcome back, everyone, for the Creating Inclusive and Anti-Ableist Triage Policies presentation. I am happy to introduce our presenters, Dr. Laura Guidry-Grimes, Associate Staff Ethicist at Cleveland Clinic's Center of Ethics, Dr. Katie Sabin, Assistant Professor for the Social Work Division at California State University, Sacramento, and David Whalen, Project Director of Disability Awareness Training at Niagara University. Welcome all. Please introduce yourself and provide a self-description.
I'll start. I'm David Whalen. I am a 60-year-old white male wearing glasses with graying hair, wearing a white shirt that is vertically and horizontally patterned with thin lines. With a pen in my pocket, I'm in my office with several pictures and other clutter over my shoulder.
My name is Laura Guidry-Grimes. I'm a white woman with dark hair that is definitely graying, wearing a black blouse with flowers that are white, purple, and pink, and a black cardigan on top of that. I'm sitting in a black and white chair, and behind me there are books and photos of my family and artwork from my dogs.
Hello, my name is Katie Sabin. I am a white, non-binary person with short, dark, also graying hair. I'm wearing glasses and a green colored shirt. Behind me, I have a Zoom background to hide my mess, and it's white bricks with a plant on the side, maybe a ficus.
And Dave, do you want to start us off?
And could you put the PowerPoint presentation up, please?
It says it has disabled screen sharing. All three of us need to have screen sharing enabled.
Oh, it looks like mine's working, so I will sorry. Oh, you got it. Okay.
And here are our three categories that we have come together to work on. I am reading in the anti-ableism and inclusion definitions. Dr. Guidry-Grimes will be going through foundations of crises, standards of care, and formal and informal triage. And Dr. Sabin will go through anti-ableist triage recommendations. This is Dave Whalen. I will be starting it off. You have a green screen here, a green background with white print. On this page is children of diverse background, 2 wheelchair users, and on the pages moving forward that I will be presenting on is our Niagara University Emergency Management Disability Awareness Training logo and our website, frdat.niagara.edu. The slide, inclusion. First of all, when we talk about ableism, in simple terms, not to feel that there's not a need to post it, but just to explain it, it's discrimination against people with disabilities. So in our short time here, we're going to dive more into what that means in the context of emergency planning, preparedness, response, and recovery, and in line with what my colleagues here will be speaking on when I complete this discussion. A term used by people with disabilities and other disability rights advocate. And I always stress, first of all, look who uses this term. It's not the government. It's not parents. It's not medical professionals. It's not educators. It's people with disabilities and disability rights advocates. If you look into the National Council on Disability, they will identify inclusion as one of the major topic areas, if not the leading topic area in proper response to people with disabilities, which certainly goes beyond this topic area. We look at employment and the discrimination in that context, amongst other areas. Continuing with the definition, all people should freely openly and without pity accommodate any person with a disability without restrictions or limitations of any kind. So I point to the key terms in here: without pity and accommodate, amongst the other terms, without restrictions or limitations of any kind, which we can see frequently in many contexts throughout the course of any individual's needs specific to disabilities. When we say accommodate, understanding that term in its various forms, for instance, in schools and in employment settings, workplace settings, reasonable accommodations and modifications and how they come to play. In the context of disaster or emergency needs and planning for people with disabilities and access and functional needs, we are looking to accommodate, in very simple terms, areas like shelters and general effective communication, some things that we have really seen throughout the course of these 3 days and in this program as it's been discussed. What might a person need? What might an individual need? And on this page is a little box that has emergency preparedness checklist with a pen on it. So what is someone in need of specific to, again, emergency planning and preparedness, response and recovery? Durable medical equipment, and defining what that is. What we often find is people know these terms, but they're not sure what it is. So it's important to define what these are. What is DME? How does it come to play, again, in this context, this setting, that the intents of these presentations this week? Personal medications, and think about medications. Raise your hand if you're taking a medication. I am. What does it mean if we're going to be absent that medication for an extended period of time? Or, to varying degrees, even a short period of time, depending on the individual. Adaptive equipment, and defining what that is. Utensils with fat grips, different need areas specific to an individual. I'm the parent of a son with spastic quadriplegia, cerebral palsy. He's a power wheelchair user. He has low vision, a learning disability, and a speech disability. These are all parts of my everyday life. His adaptive equipment is in his backpack. Is it with him in times when he may not be with his parents? Have we educated his aides on that? Assistive technology, and what technology is doing today specific to people with disabilities as far as the areas we're talking about, and again, beyond here today. But where is that as far as planning comes to play, and then access to those items? Power wheelchair chargers, hearing aid batteries, et cetera, et cetera. The list is lengthy. If people are not aware, every state by law has to have an assistive technology program. In New York State, we have the technology related assistance for individuals with disabilities or trade. You can find that through websites. Each state has those programs whereby people are able to identify the need areas here, usually not knowing all that's out there. There's a lot of quality, top-notch equipment and technology out there today that people aren't aware of that would also be specific to, their needs. And how about the absence of those, say with separation, going to a shelter, not being home when they need to evacuate a particular site. Transportation, which in its simplest form is the ability to have it. Do I own a vehicle where I can transport on my own? Or if I need accessible transportation, is it available? And then the millions of Americans that don't drive for whatever reason that is, from aging to disability to the inability to drive to the areas where they live. Major metropolises don't promote having your own transportation. They promote public use. And then other health and medical needs. Next page, please. So, what is ableism and what are we talking about in the context of this program? Well, let's look at the New York City lawsuit. When New York City lost a lawsuit, the third major city in the country to lose a lawsuit specific to inappropriate response to people with disabilities in an emergency setting. This is the judge's statement. Unfortunately, despite the obvious importance of accounting for the unique needs of individuals with disabilities and planning emergencies, New York City's emergency plans, like many state and local emergency plans throughout the nation, failed to do so. He was simply recognizing that, yes, New York City, you were not prepared and you did not do it right. But I'm very well aware and certain that many other municipalities across this country are not prepared. And that is generally the case. Now, let me soften that statement a little bit by saying this. We work across the country in several states with our emergency management training. It's not for a lack of interest or effort on most parts. It's for a lack of ability to know what exactly they're supposed to be doing. Where do I access information on the ADA? What is a core advisory group? You want me to connect with people with disabilities in various formats? Who are they? Where are they? Where do I start? So we need to understand that this is a process that leads to proper response. But we also need that effort put forward by emergency management offices and municipalities just the same. And we always say start with your independent living center. So I want to reference this in context to what I just stated as far as emergency managers being prepared and having an idea. Inclusive disaster preparedness planning. This is a case study that came out of the University of Albany's law school, which was formerly Civil Rights and Disability Law Clinic in Bridget Burke. I was on the New York State Independent Living Council for 6 years, and I was the chair of the Emergency Preparedness Committee when the Superstorm Sandy came through New York City, Long Island, New Jersey, and the eastern part of New York State, western parts of Connecticut, Massachusetts, and Vermont, and certainly it kept going into Canada. And what we did with the efforts by Bridget Burke was to come together with this study here to reach out to counties that were affected in New York State, on the eastern part of the state. And her quote is this: a lack of inclusion of individual with disabilities in disaster preparedness or disability awareness may well be the result of the tendency of Americans to infantilize individuals with disabilities. Much of society focuses on dependence of individuals with disabilities and not their strength. While during an emergency, many of us will depend upon assistance from others, if not all of us, and some codependence is a part of a healthy society, we somehow are incapable of looking beyond this codependence of individuals with disabilities. So the concern being how we're seeing the individual, their ability to contribute, or quite frankly, seeing them as being a lesser person. That is ableism. So when I say we're going to define ableism, we're going to define it in this context. So let me play off a little bit about what Bridget was talking about. What we did was end up doing a full outreach to 10 counties. We had 10 counties. We had counties say to us, where have you been? We are in need. We have been looking for something like this. Thank you. We had counties that we need to do a Freedom of Information Act. These are counties that border each other, same state, same intentions, but had no interest at all in talking to us. And then interest in, of course, getting supports. We asked 6 simple questions: physical accessibility of shelters and accessibility plan, with the intent that they were surveyed and completed by independent living centers or other disability organizations. Accessibility of communication, accessibility of evacuation and transportation, representation on committees of independent living center, organizations serving individuals with disabilities and or individuals with disabilities, disability awareness training for first and emergency responders, and involvement of people with disabilities as volunteers and first responders. That was what we were simply asking. If you view that in the context of ableism or a lack of seeing people with disabilities as contributors, note where that's going. Did we include people? Did we talk to them? Did we completely ignore them? And as we developed our emergency plans, was the result of our challenges during that hurricane and others, based on our lack of awareness, in essence, not attempting to reach out to people, an ableist mentality. What you're looking at here is, it's actually a FEMA slide, which FEMA will reference and use the term whole community, which we embrace. Understanding your whole community sounds simple in the fact that you hear whole community. Well, of course, my whole community is everyone around me. Well, who's in your community? You know, do you have how many skilled nursing facilities, senior care, assisted living? You know, go across the plethora of senior services, developmental disability service providers, day programs, residences, mental health supports, homeless shelters. Do you understand the people in your community from a migrant standpoint? Different languages spoke. The county I live in, Erie County, we have 53 languages spoken in Erie County. So that's your whole community. You identify and recognize your whole community and those need areas. This I guess I'll call an oval graph. I don't think that's the exact term for it, but someone out there probably knows. That circle with people with disabilities, what you see, I should describe this, I'm sorry. You have a red circled egg-like circle here that says whole community. Within that, you have a light blue circle that says people with access and functional needs. And then within that, you have a circle that's pretty much round that says people with disabilities. 26% of the American population, according to the CDC, Center for Disease Control and Prevention, people have a disability. This is accurate to that size. Somewhere in the range of 60 to 70% of your community is people with access and functional needs. So the blue graph here is actually indicative of the number of people who may, not will, may have challenges in a disaster, in an emergency. That's a lot of people. And for any naysayer out there that says that's too much or that's too high, let me cut that in half just to simplify this. And that would be 1/3. That's 33% of your population. That's a lot of people just the same. So let's understand what we're going up against and bringing those people into play as we move forward on our plans. So if you caught the first speaker, Coco, he had talked about intersectionality. What's on this page is an intersectionality heading with a circular intersecting globe-like picture, which recognizes race, 1, race, 2, ethnicity, 3, gender identity, 4, class, 5, language, 6, religion, 7, ability, 8, sexuality, 9, mental health, 10, age, 11, education, 12, attractiveness, and many more. Intersectionality is a lens through which you can see where power comes and collides, where it locks and intersects. Is the acknowledgement that everyone has their own unique experiences of discrimination and privilege. Kimberly Crenshaw, a Cornell University professor in 1989, coined this term, which was based off of the labor strife at General Motors, specific to black males, and then black females not being promoted. And intersectionality comes to play with where ableism is based. So if we're saying ableism, tell me what that means. If we're saying racism, if we're saying sexism, if we're saying autism, classism, define that. In the context of disability or ableism, it's barriers, really. Now, I would take the position that no one consciously erects barriers so people with disabilities and access needs can be excluded. I would think most people out there say, we're not going to make our restaurant accessible so I can keep out people with disabilities. I don't think that's the mindset. But what barriers is in this context and what we go up against from an ableist standpoint is just that. What are barriers? Well, attitudinal, this is actually also a CDC breakdown here. Attitudinal or attitude starts with attitude. What's your mindset? Are you, the very fact that people are on this call says you have a positive attitude. You're looking to learn. You're making a step forward. What are you reading? What are you doing? How are you understanding this? Or when I go to certain states that I'm in and I have no emergency managers attend an emergency management training, what's the attitude there? Communication and understanding what general effective communication is, what's accessible communication. Physical barriers. Be the 1-inch lip at going into a store, a restaurant, or an office for that matter is not only inappropriate, it's illegal by ADA standards. We just put a physical barrier, but we might not be aware of it. Hence the need to understand, and really hence the need for DRNY doing this whole program. How's your policies read? Are they restrictive, or do they even include it? I've had people on campus here. I'm also the ADA coordinator. I've had people on campus here say, well, what's the policy read about service animals? Well, here's what the law says. Well, what's the policy read? Programmatic. What programs are programs accessible? Once I'm inside, can I get around the space because they're the area of facilitation, restrooms, etc. Social barriers, and then again, transportation. And then we want to really just pull together the concept of not just universal design, but universal accessibility. So flipping what do we need to do? We need to embrace universal accessibility. How do we break down those barriers? Universal accessibility. The difficult task involves social transformation. Think about that. We need to transform mindsets, society, a reconfiguration of an environment eagerly seeking change, as well as new actions and strategies. Promoting and working for universal accessibility means acknowledging. It starts with acknowledgement. I'm not doing it right. the rights of people affected by the various barriers imposed by the environment, and the advantage that accessibility offers to everyone, regardless of their situation. You know, whoever I am, is this going to be universal accessible to anyone walking into my structure? Next page, please. And then to close out my section here, unfavorable attitudes to disabled people rife among medics, says new study. The study's source is Dr. Izoni et al., Physicians' Perceptions of People with Disability and Their Healthcare, from the Health Affairs write-up in 2021. Now, the first statement on here is my statement, not hers. Medical professionals and disability awareness and proper response are not synonymous. I find so many people, new parents especially of children with disabilities, who will look to medical professionals for direction, which may be the worst place to go. No discredit to the medical professionals. They are all aware of it. It's not you don't get trained in disabilities in med school. You get trained in how to respond to medical needs in med school. And, you know, we've seen these areas come to play. Picking my son, the right son and the right doctor and dentist for my son was a process, not just a pick. But to her statistics, 80% plus of 714 US doctors surveyed affirm that persons with disabilities enjoy an inferior quality of life to that of non-disabled people. 40.7% of participating physicians from a cross-section of specialisms reported a high degree of confidence in providing a similar quality of care to patients with disabilities. And 56.5% of physicians strongly agreed they welcome patients with disabilities into their practice. Those are very alarming numbers, which lead into my co-panelist here, Dr. Laura Guidry-Grimes' presentation. Take it away, Laura.
All right, thank you so much for that. So I'm going to pivot a little bit to talk about some basics of public health emergencies. I apologize if this is well known to certain folks who are tuned in, but I hope you'll bear with me. Just want to make sure we're all on the same page when we talk about crisis standards of care and shifting conditions. So in a public health emergency, we are not looking anymore at normal conditions, right? We're starting to move away from that. So on this slide, you see a dial. We're under normal conditions. When we're aimed towards that, we have patient-centered decision-making, at least ideally, right? That's the aim, that's the hope, which means, say, fidelity to the individual patient and respect for the rights and preferences of patients. When we move into public health emergencies, you have this shift into community-centered decision-making, where the aim is more towards promoting public safety, protecting community health, and fairly allocating dwindling resources. So the ethical orientation is importantly different. I showed that with the dial moving towards public health emergencies. And there are some universal ethical considerations across these, but this shift in orientation, I think if you experienced any healthcare space in the last few years, you really felt this. This is a visually complex slide. I do have full image descriptions available for these slides. But this is from the Institute of Medicine, their 2012 report on crisis standards of care. And so what you see here are as you have this move from conventional standards of care to crisis standards of care, that you have dwindling resources, right? And the risk of morbidity and mortality to patients increase. And so the three kinds of resources that we're concerned about are space, staff, and supplies. So it's not just ventilators. There's almost an overemphasis on ventilators during COVID-19, but it's more than that: space, staff, and other supplies as well. Dialysis machines, medications, pain management, all became very difficult during the pandemic. And so when we shift from conventional standards of care, right, that's where you have usual patient care, usual staff, cached and usual supplies, with contingency standards, which were underemphasized throughout the literature, historically and even now, you have this straining of the healthcare system. And so we saw prolonged contingency standards of care during the COVID-19 pandemic. So with space, you see things like the repurposing of spaces. You see staff extension, which may mean you don't have the same level of trained staff, nursing ratios can change and whatnot. With supplies, you have conservation, adaptation, and substitution of supplies, and occasional reuse. So we saw that with PPE, for example, personal protective equipment. You had healthcare professionals having to reuse equipment that was meant to be disposable. And so the IOM, I'm just going to go ahead and say, right, spoiler alert, they call this functionally equivalent care, and I think that's a mistake. I think we saw in a really pronounced way, though, how contingency standards of care are not functionally equivalent, and I'll talk more about that. And then with crisis standards of care, right, this is the nightmare scenario, what everyone wants to avoid. And the reality of the COVID-19 pandemic is most states did not authorize crisis standards of care. Most healthcare systems did not actually go into it, but they had to prepare, right? So they are preparing as soon as they can for the nightmare scenario to try to make it as least of a nightmare as possible. And so there's a lot of focus on crisis standards of care, and there's good reason for it, but we can't neglect these other strains on the system in the meantime. So in crisis standards, you have a facility or space that is damaged or just unusable, right? So Hurricane Katrina is an example where the facility was actually damaged in lots of areas, right? And were unusable. With staff, you have like trained staff who are actually unavailable, right? You have units that have to close because we don't have people to staff them. And then you have critical supplies missing. And so we actually have to reallocate or just not provide certain critical care resources, right? So those are crisis standards of care. And as I alluded to, you actually need government empowerment in order to move into crisis standards of care. There's a whole process that needs to be followed. All right. So this graphic is also taken from, well, I created it, but it's based on what the IOM report has. And this is just showing how you have this need for critical care resources increasingly outstripping what's actually available and what that means in terms of supplies and staff and space, right? So you have this move from conservation to substitution and adaptation to reuse to reallocation. Right, so each of those is a step closer to crisis standards. And I wanted to just emphasize that there are many ethical issues that affect patient care. Again, a lot of things that I worry did not receive proper attention before the pandemic, and that we know need a lot more attention. And some of these areas, right? So the dangers of congregate care, this is well known to the disability community, right? This is well known to disability rights advocates, and yet it wasn't as pronounced for a lot of healthcare professionals until the pandemic, which is really sad. So when it comes to discharge and congregate care, limiting hospital and facility visitors, that was a daily source of ethical concern. Of course, resource allocation, limiting CPR, right, especially for a virus that can get aerosolized. Patient isolation and quarantine, right, the lockdowns, there are lots of ethical issues that go along with those, as well as postponing elective procedures, where elective does not mean that it's not medically indicated or beneficial for the patient, right? It's just not medically necessary right then. But there are lots of ethical issues that go along with postponing. And so to say a little bit more about contingency standards, you know, the goal is to have patient-centered care, but as well articulated by Frith and her colleagues in a 2021 article, they say, it is situations where patient-centered functionally equivalent care either cannot be achieved, right? So that selling point from the IOM that it's supposed to at least be functionally equivalent because we've adapted to a strained environment, it doesn't actually provide functionally equivalent care. Or what counts as functionally equivalent care is contested. That is, it is equivalent in one respect, but not in another. That is the interesting, arguably distinctive ethical issues and dilemmas arise. And so as far as what gets chipped away, what gets lost when we have these contingency standards, right? So again, where we have a strained healthcare system that hasn't hit crisis, but we're certainly not in a conventional mode, right? We do have strains on space, staff, and supplies. One thing that gets chipped away is caring, right? So interpersonal relationships are not equivalent when everyone is wearing protective personal equipment in the room, right? You have strained and more limited staff. You have burnt out staff. You have changing ratios on a daily basis. You have people traveling from one institution, one unit to the other, right? All this affects attention to individual patients. Patients aren't necessarily getting turned as often as they ought to, right? It really does affect patient outcome as well as patient experience and that relational component to healthcare that's so important. And visitation restrictions. So especially for disabled patients, and I'll say disabled persons or persons with disabilities, I will use patient language occasionally just because I'm focused on hospital systems for this conversation. With visitation restrictions, those were really disproportionately impactful for disabled people who relied on caregivers who know their needs well, who can facilitate communication, who can advocate for someone who's disabled and ill in a way that others can't, right? So those visitation restrictions were really problematic and really dangerous for a lot of disabled patients. And equity is also a concern. So you had throughout hospitals, there have been actually a number of empirical studies on this throughout the pandemic, hidden systems for visitation exceptions and patient advocacy. So you would sometimes have like families allowed to visit when other families weren't allowed to visit, and not necessarily through principled decision-making. You had regional inequities in the patients served. So most states and regions did not have planning to ensure that you had like load balancing and ways to make sure that strained hospitals were able to transfer patients to other hospitals that weren't as strained. And that's a problem, right? You have inequities that accrue in socioeconomically deprived areas as a result. And you have the phenomenon of informal triage, which I will talk about more in a minute. And so when we ask, well, what falls through the cracks of a cracked system, right? It's some of the patients who are rendered vulnerable in clinical environments as it is, who are vulnerable in a pandemic as it is, who are the first to fall through those cracks. And so this is not functionally equivalent care. And I think national guidance has to dispel of that notion immediately. All right, and so I want to make sure I leave room space for my colleague Katie. So I'm going a little quickly. I apologize if it's too quickly, but all these slides are available, and I'm available to discuss anything after this presentation. So please forgive me if it's too quick. So when it comes to formal triage, informal triage, and identifying ableism, there is a lot to say here. And I think there are a lot of misconceptions about the triage process and crisis standards of care out there. And so one thing I want to say is that medical appropriateness is always the first question with triage when we talk about crisis standards of care. So if a patient is, there's significant medical certainty that a patient is going to die with or without a ventilator, just to use ventilators as an example, that they would die anyway, then they should not receive a scarce ventilator. If there is confidence that they could survive without the ventilator, then they should not receive the ventilator either, right? So medical appropriateness is the first question. And then we have tiers, right? So these triage protocols, they have different tiers. So there are different ways of prioritizing patients at one tier. And then if there's a tie among too many patients, then there's another tier that sets out another way of prioritizing patients, and so on. And so the other thing is that these decisions, these assessments, are continually reevaluated. It's not a singular decision if the system is set up well, right? And so Ideally, you have a triage team with an accountability mechanism who are reassessing decisions that are made within the triage system. So there has to be that nimbleness. There has to be that individualized assessment as much as possible in a nightmare scenario. So there's no such thing as a perfect triage system. No one is going to say that, the SOFA assessment or any of these other tiers for a triage protocol are great, perfect, ideal. No one's going to say that. I guarantee you, right? It is a nightmare. Everyone wants to avoid it. There's no such thing as a perfect triage system. And value trade-offs are inevitable. With that said, there are better and worse ways of doing this, of course. And so there are lots of approaches that have been discussed historically and currently in terms of how to approach triage, what values should guide the decision making, and then how do we operationalize or enact those values in a policy process that's feasible in a nightmare scenario, right? That's the context for all this. And so in front of you, you'll see a table with a lot of different kinds of principles and descriptions of what that could mean in practice. I'm just going to focus on a couple of these. So prognosis for short-term survival is potentially something that should be a cutoff, right? So patients who are not expected to survive short-term should be deprioritized, arguably, compared to patients who are expected to survive short-term, right? Now, of course, we have to define what short-term means. And so that's one way of setting a criterion, though, is trying to figure out what we mean by short-term prognosis and going from there. A lot of hospitals across the United States, at least, considered this. I think that was a global consideration too, but I've studied US triage protocols more. And then prognosis for a long-term survival. This one is much more controversial, and it is what a lot of hospital systems considered, especially in the beginning. And as you had fantastic advocacy by disability rights organizations across the country, more hospitals got rid of this consideration. So the idea here is that patients who are likely to survive the most number of years are given priority, and underlying illnesses the patient already has are considered, right? Those are relevant for triage considerations, right? This opens the door for a lot of disability discrimination, obviously. And also, medical professionals are not super good at long-term prognostication, right? So there's a lot of error as well as discrimination potential. And so what you had in the literature, right, was increasing debates over the last few years about what counts as a just or equitable triage protocol, right? Because we can't just avoid writing triage protocols, because then we're going to have excess mortality. That is, we're going to have people who die when those were preventable deaths if we had planned appropriately, right? So we want to plan appropriately so that, again, the nightmare possibilities are minimized. But then what does that look like? What should it look like? And so you have this article in the New England Journal of Medicine from 2020 that is one of the most cited, if not the most cited article in that juxtaposition of public health ethics and triage, where they say, the authors say, priority for limited resources should aim both at saving the most lives and at maximizing improvement in individuals' post-treatment length of life. Saving more lives and more years of life is a consensus value across expert reports. In response to this, you have Ari Naiman in the New York Times, and this was echoed by a lot of scholars in disability bioethics, disability studies, disability rights activists across the country. Naiman says, by permitting clinicians to discriminate against those who require more resources, right, which are often, disabled patients, right, multiply marginalized patients, perhaps more lives would be saved. But the ranks of the survivors would look very different, biased towards those who lack disabilities before the pandemic. Equity would have been sacrificed in the name of efficiency. And so what you have here, like beautifully articulated, is that do we care about efficient use of resources in a nightmare scenario in a public health emergency? Of course, but we can't just be pursuing efficiency to its brutal conclusions, because we're going to end up discriminating against those, disadvantaging those who are on the losing ends of all sorts of structural inequities already with our healthcare system and with health determinants outside of the hospital, and disabled people are going to lose out as well. So I'm going to skip this slide because it's what I already said, but I will focus on this last point, that equity according to disability rights means focusing on removing disability bias, right? And providing more resources to disabled persons when needed without viewing it as a quote waste. All right, so we want to ensure disabled people have the same chance of receiving maximum healthcare as their non-disabled peers, right? That's why equity is the key term here. And as Dave and others through this webinar series have mentioned, the Department of Health and Human Services has an Office of Civil Rights that received formal legal complaints about disability discrimination in triage protocols throughout the country. These are a couple of examples. They are not comprehensive. So I'll just mention Alabama, their very old triage protocol, which I read before they removed it from their website. It explicitly, categorically excluded anyone with, quote, severe or profound mental retardation. They did use that term, moderate to severe dementia or severe traumatic brain injury. Right, so that categorical exclusion based on disability status was found to be illegal. So they had to change it. In New York, the concerns included that personal ventilator reallocation could happen under New York's guidelines. And so there are these concerns that people with ventilators in the community, they could come into a hospital and maybe those ventilators could be taken by the hospital for use for others. And there's concern that their triage protocol would disqualify persons with disabilities simply because they have underlying conditions that may intensify symptoms and slow recovery. So that was among the concerns with New York's 2015 ventilator allocation guidelines. All right, and then when it comes to informal triage, so this is, informal triage is not discussed much in the literature from what Katie and I have found. Katie and I have a chapter that's forthcoming on this topic. And what we mean by informal triage is that these are decisions to deprioritize certain patients or deny medical interventions due to concerns about current or potential scarcity that are not based in formal triage protocols. So, in other words, you have the, the phenomenon, the experience where healthcare professionals are making triage-like decisions, even though they are not in crisis standards of care, even though there is a formal process to follow for triage according to policy that's been vetted, that ideally has been made transparent to the public, that's gotten approval by the relevant folks. You have healthcare professionals making allocation decisions outside of that framework because, say, they're in contingency standards of care, or maybe they're in crisis standards of care, but they're still not following the formal process. So this is really scary, right? And I got really curious about this because in my role, anecdotally, I heard about this happening throughout the country, and yet, there was some news coverage of it, but it didn't seem like there was enough attention to this phenomenon, right? There's more focus on the formal triage protocols. So we don't know how common this was, right? Because it wasn't empirically captured. And so informal triage is not necessarily based on full information about surge capacity or up-to-date information about the public health emergency or care options for patients who, have, say, COVID and then such and such other kinds of medical illnesses or medical needs. And so they're making decisions without all the information that they would need to have. And it's often made by individuals in a strained and hurried system, right? So my presumption with anyone who conducted some form or performed some form of informal triage is that these are not like evil people looking to weed out the population or get rid of patients, right? These are people who are strained and burnt out and trying to do the best they can in a strained system, in a hurried system. But, right, informal triage is incredibly dangerous, likely underinformed, and doesn't ensure anything like transparency or fairness or accountability or anything, right? So it's a terrible practice. And so this is an article from NPR from Joe Shapiro, right? He did, heroic work with journalism during the pandemic. And the title reads, "Oregon hospitals didn't have shortages. So why were disabled people denied care?" And so in this article, he describes how a woman was taken to the hospital with COVID-19, but the hospital in a small Oregon town denied the ventilator she needed. Instead, a doctor, citing her low quality of life, wanted her to sign a legal form to allow the hospital to deny her care. In addition, hospital staff sent word to her group home, telling the staff at the group home to fill out DNRs for their residents in case any of them come to the hospitals, right? So this like proactive DNR push, right, is, it's happening in this strained system. It's a form of informal triage and inappropriate decision-making that's made by hurried folks who think that they are doing right by, their patients collectively, but it ends up being deeply ableist and discriminatory against persons with disabilities and especially those who are multiply marginalized. I'm going to not go through the case of Michael Hickson. I'm happy to talk about it if we have time, but this is a case also covered by NPR and other news outlets, where you had a disabled Black man who was denied ventilator, right, mechanical ventilation, and remdesivir because of the doctor's concerns about his quality of life, which he stated explicitly to Mrs. Hickson. And with that, I'll turn it over to Katie, and I'm going to stop sharing because she's going to share her own slides, my understanding.
Yes. Okay, can everyone see those? Great. Okay, hi everyone. So I'm going to wrap up our presentation with some recommendations around both informal and formal triage to encourage anti-ableist practices. And these are all developed in the context of the chapter that Laura mentioned that will be forthcoming. And they're, they may apply to the institutional level, the state or local level, as well as an individual level. And they come from both lived experience of disability, as well as being embedded in a disability community and being engaged in the research on this topic. So this slide has a few just initial recommendations for things that can be done on an institutional level, that importantly can be done in between emergencies as well as during them. And it is very important to put time when there is not an emergency to be looking at assessment and tracking and improving how we might do triage. As Laura had mentioned, being rushed and overworked and burnt out often can lead to ableism. So first, conducting an assessment, an institutional assessment of informal triage, these practices that are not encoded in policy, but may be taking place through surveys of both staff and patients. And through those surveys, as well as input from various stakeholders, trying to work to identify what are those key decision-making points that could permit this inappropriate and unsanctioned informal triage. For example, Could it be when determining whether to transfer a patient to a higher level of care, or determining whether to offer a particular medication or antiviral even? And being able to focus in and seeing, are there ways that once these points are identified, we can implement protocol that might mitigate the informal triage. And then developing monitoring and tracking systems. So Laura had mentioned one of the pernicious factors about informal triage is that there is a lack of accountability. So how can we introduce some accountability into this practice? And develop systems that can be used both by patients and by staff of all sorts. And then in addition, in terms of documentation, ensuring that when demographic data is collected on patients, that information about disability status, type of disability, and any needed accommodations are being collected so that that information can be analyzed alongside information around triage, informal and formal, to assess for inequities in outcomes, both related to disability as well as race and gender and insurance status and all of the intersections of those identities. And then particularly between emergencies, to be revisiting triage protocol and other crisis-related institutional policies, to be incorporating community input, making these proposals public and accessible for community to comment on, both to improve the policies and to hopefully really increase and foster trust with communities. Okay, so this next slide is going to focus on practices and recommendations for providers. So institutions, we absolutely recommend provide trainings on implicit bias and ableism, as those are two things that alongside, lack of resources and time can create an environment for informal triage, an ableist informal triage. And we can presume that because of lack of training, because we're embedded in an ableist society, that not having this training will inevitably lead to this type of discrimination. So making sure to offer that, also developing pipelines to health professionals for people with disabilities, so that the ranks of people who are staffing our hospitals and nursing homes can look more like the population they're serving. And this includes for clinical bioethicists. And also to really bring awareness to this issue more to the to dialogue in hospital and nursing home and institutional levels. So Laura had mentioned the case of Mr. Hickson, who was denied care due to inappropriate perceptions around his quality of life. And this type of case is really important to be talking about. Again, it's likely underreported. We don't have a lot of information about it, but when we do know about these really awful cases, these are important things to discuss on a hospital level in practices like grand rounds or other hospital-wide or institutional-wide settings. Okay. Sorry, I'm just checking my time. Okay, so we also recommend that community, all sorts of communities, including disability communities, are involved in the practice of developing anti-ableist triage. I think the overarching principle behind this is that when a provider meets somebody with disability in the context of being their patient, this should not be their only context for interacting with a disabled person. We obviously exist outside of a hospital and patient context, but it often is, often we're in segregated communities. So how can we make sure that providers can have an imagination of what a full disabled life looks like? There are a number of ways that this can happen. And in these recommendations, we want to emphasize that disabled communities, disability communities look different, right? There's different racial and ethnic backgrounds, cultural practices, languages, gender and sexual identities, and these all should be represented when we're talking about disability communities. So some ways that this can happen, you can hire disability organizations or disabled individuals to conduct those anti-bias and anti-ableist trainings for staff. You can invite disability communities to participate in boards and committees in your institutions to develop these protocol and just to have kind of routine community input. And when you do these things, like invite people in to provide trainings, we encourage you to offer compensation for this labor. And a couple more factors to think about more on a macro policy level. So as Laura mentioned, it was not extremely common to actually get to crisis standards of care. However, there are all kinds of ways that not having enough resources does create the conditions for triage, both informal and formal. So we really need to increase our funding for innovation and critical care. We don't want to think of that, we want to avoid situations where people's personal durable medical equipment could be repurposed for broader use, and instead think about what kind of medical innovations can we use to expand capacity and make sure these innovations are protecting and not endangering disability communities. And then also think about arrangements for agreements for resource sharing. So there was a lot during the COVID-19 pandemic. There were situations where hospitals and states were having to place bids and compete for these critical scarce resources. And this type of competition only reinforces and exacerbates inequities that can take place both on regional levels as well as on more community levels. So having more equitable processes and more resource sharing can also help avoid being in the place to begin with where you're making a painful triage decision. And then I think this might be the last one. On an individual level, as a person with disabilities, there are a number of strategies that you might think about when you go into a hospital or institutional setting where you're worried about these things we've been talking about around informal and formal triage. And there are strategies that, I know I've developed in my own life and in my community. There's lots of organizations run by disabled people that try to provide recommendations. And this is one that kind of comes from a combination, and there's we'll share a source later from the group Nobody is Disposable. But they talk about making something like connection kit. So bringing information into the hospital with you that can really reaffirm your humanity. Often when we're in the hospital, we don't necessarily have the ability to communicate to ourselves, to present ourselves as the full humans we are, living well-rounded lives, not just as patients. So bringing information about you, about what brings your life quality, photos of yourself with people you love, can really be helpful. And also, as much as possible, of course, bringing someone with you to help advocate and to present you as the person who you want to be seen as. So the next couple slides, I just have listed out recommendations that are sort of summed up from really all of our presentations together. And I don't have time to go through these individually. So they are provided in the slides that you received. So I'll just end with this last slide. We have a resource list compiled with citations as well as additional resources and reading from the information provided in this presentation that you can access at this QR code, which you can read by opening your smartphone's camera and hovering over the grid in the middle, and then opening the website when prompted, or by clicking the link that I believe Laura is putting in the chat to the link tree. And we also have our emails here that where you're welcome to contact any of us or all of us for more discussion. Thank you.
Thank you, Laura, Katie, and David. And thank you to all of you who have joined us today. If you have questions, please email emergencypreparedness@drny.org. The recording of this event will be made available on our YouTube channel within 2 to 4 weeks.